In this course, we're going to learn more about late loss ADLs and what they are and what impact they play within nursing facilities. Accurately coding late loss ADLs is very important, as late loss ADLs impact the plan of care, payments, staffing, and acuity. So knowing what the late loss ADLs are and how to code them is extremely important. What are late loss ADLs? Late loss ADLs are considered the last ADLs that a patient will start to lose the ability to perform as they deteriorate in their health. Research indicates that late loss ADLs predict how many resources we need within our facilities. They determine how much assistance is received by the resident and how many staff members it takes to care and provide the resources that the patient needs. So the staff time, the number of staff, the staff effort provided by the facility is all noted in the ADL coding. So making sure that we code the highest level of care that we're providing is extremely important. With ADL self-performance, we're really measuring what the resident actually did, not what he might have been capable of doing within each of the ADL categories, but what he actually did during those 7 days. What was the performance and how did the patient actually perform the activities? We should document every instance of the ADL that is performed every day over the 7 shifts. So every time we complete a task, we should document that in the electronic medical record. The documentation is completed over 7 days, and we're looking at how many times the ADL occurred at a certain activity level. And then when the MDS coordinator is analyzing all of this data, she will use the rule of threes to determine what to code on the MDS. And what she's looking for is the self-performance of all of the different tasks over all of the shifts, and she's looking for which one occurred 3 times. If one of the ADLs was coded 3 times, then that is what will be coded on the MDS, using the highest level of performance in accordance with the RAI manual. The only exception to this rule is for coding of dependent. To code dependent on the MDS, you would need to be dependent on every shift. We should always make sure that we're documenting what occurred, really looking at the electronic medical record and each point of care to determine if multiple entries were used. Did we speak with the staff to ensure that they recorded all of the information? We should also consider paper documentation. Did we have any paper documentation that occurred that we need to make sure is scanned into the medical record? Or did we have any issues with our EMR during our look-back period? If the answer is yes, we would need to track down that paper documentation and make sure it gets into our EMR. We should never code based on what is expected or what we think the patient is capable of. We always want to look at what the patient actually did and if we were able to provide support naturally. And honestly, that might vary from day to day, shift to shift, looking at the medical condition, the functional, psychosocial, all of these different items play an impact on the ADLs. So we want to make sure we're coding what occurred, not what typically happens. And that's one of the mistakes that we see frequently in ADL coding. We should look at the look back period and pay close attention during this 7-day time frame. We only complete an MDS on a quarterly basis. So every 92 days, we're looking at a patient's record and we're setting a look back period where we're going to be looking back in time to evaluate how this patient did. We want to make sure that the ADLs aren't fluctuating too much or we're not seeing any huge changes. If so, we might have a significant change. So we want to make sure we're really paying close attention and providing education during that time frame. We could also observe different times of day to make sure the documentation looks like it is changing and that some of our team members aren't just copying what the last person wrote. So during that look back time frame, we really want to monitor that look back period. Here are a few important reminders for ADLs. Residents are not the same day to day, shift to shift. Residents vary at different levels and different times of the day. Mood and behaviors, sometimes sundowning, resisting care, being depressed or confused, can impact the ADLs. Medications such as pain medication, sleeping medication, as well as cognitive status. The resident's ability to understand others can sometimes vary throughout the day. And then medical conditions. Maybe a patient has arthritis and requires pain medication, and that might impact their ADLs. They could have an infection or a virus and require more needs. So make sure you're looking at all of those different aspects when you're completing the ADL documentation. Here's a helpful little tool to help you remember some of the steps in gathering all of the documentation required for ADLs. If you can remember to corral your staff and get them all together, I think that word corral is going to help you remember all of the items that we need to do. So that first C in corral, consult with the interdisciplinary team. You want to meet with your nurses, CNAs, therapists. You want to have a well-rounded group of providers giving you information and input. We want to ensure that there is consistency and communication together, accurate information about the residents' abilities and their functional status. We also want to confirm with all team members that we're aligned on the assistance that we're providing during that shift. So maybe you are speaking with the IDT and we note that the patient was independent and somebody says, no, I helped that patient with bed mobility. Then we would need to make sure that they go in and make that entry into the electronic medical record. Observe. We're going to be observing the patient, how that patient looks at different times, particularly when they're engaging in ADLs like bathing, dressing, eating, toileting, transfers. Pay attention to how much help they require and their level of independence. The first are review the interdisciplinary documentation. So really looking for those patterns, looking at all of the different entries that are made into that EMAR. Remind the team of the subtasks and the missed opportunities if they're noted. Make sure you're providing that education and reminders. Assess each component of the ADL activity. Break the activity down into specific tasks. And for each task, determine how much assistance the resident actually needs. And then that L for look back period is to remind you that you have a 7-day look back period. And also keep in mind during a new patient admission, you have the time from when the patient admitted to your ARD. So we want to make sure that we're getting accurate documentation and corralling that staff. So when should you apply corral? You should do it while you're completing the MDS, specifically when you're looking at other sections of the MDS that may impact your late loss ADLs. So for instance, if you have a patient who's incontinent in section H, you may want to think about what the toileting code was. If it was independent, that's probably wrong because we wouldn't have a patient who's performing all of their own urinary incontinence care if they're incontinent. So start thinking about the process of corral and some of those questions as you're completing the MDS assessment. Also, when you are submitting your MDS, this would be a good time to really look at that ADL score and see, does that make sense? Does it make sense that this patient is dependent and I've coded that they're walking down the hall with therapy? Then we would probably want to readdress our ADL coding and look to see if we have an inaccurate code. So those are just a few times where you could apply the corral process. You also want to do that during admission or re-entry. Start to apply corralling the staff and getting all of that information together. If there's a significant change, we want to make sure that we apply the process. And also during care plan review, this is a great time to really look at the corral process. Did we really capture everything? Were we able to truly get a clear picture of the care that our patient is receiving? And then obviously when you are looking at reimbursement, you'll want to make sure that your reimbursement matches the care that your team is providing. ADLs really impact how much staff we have, what our patient acuity is, and if our reimbursement is accurate. So you definitely want to look at the corral process and making sure that you have looked at all of those different areas when you're reviewing your final MDS before submission to ensure you have the accurate reimbursement. When the MDS functionality is assessed on the MDS, we have two areas that we look at. We look at self-performance and staff support. The MDS was specifically designed to help eliminate subjectivity by providing specific coding guidelines for ADLs. So we're going to go over the self-performance first. The ADL self-performance has 7 levels to it. So there are 7 codes that you can use on the MDS to measure self-performance. And we're going to start with independent. Independent means no help at all. So that means your patient was able to do everything on their own. Supervision is the code 1. It means set up help only. And then we have limited assist, which is guided movement. Extensive assist, which is weight bearing. We used our muscles to push, pull, lift, or bend. And 4 is total assistance. And then we also have a 7 for activity occurred once or twice. And we have activity did not occur. So the activity occurred once or twice is not something a CNA should be coding on an EMR. This is really something that your MDS coordinator codes when she's looking at that 7-day look back period and sees that the ADL activity only occurred once or twice. And then for self-performance, this is where we're going to use the rule of 3s. So the MDS coordinator will be looking at the look back period to see if any of these codes occurred 3 or more times. If one of the codes occurred 3 times, then the MDS coordinator will code that level. And they always code the most dependent. So if extensive assist occurred 3 times, we would code extensive. But if it only occurred 2 times and limited assist occurred 3 times, then we would code limited assist. So always looking at your rule of 3s. This is a nice way to remember your ADL support. Independent, no eyes, no mouth, no hands. Is that possible? Did we take care of this patient if we didn't speak to them, if we didn't see them, and we didn't use our hands? For supervision, that's our eyes and mouth. We may have saw them and spoke to them. Limited assist is guided movement. You physically touched the patient but did not support weight. Extensive assist, you used your muscles, push, pull, lift, or bend. And then dependent, the resident could not help at all. Staff did everything. And then if activity occurred only once or twice, does that really make sense for the 4 late loss ADLs? Eating, bed mobility, transfers, and toileting. And then the activity did not occur. That probably doesn't make sense either and is more likely a coding error. So really review these, know these, and make sure you can talk to your staff so they understand these codes. The ADL definitions, independent. These are from the REI manual. The resident completes the activity without help. Supervision, staff must oversee or cue but does not physically assist. Limited assistance activity, and the staff provide weight-bearing, non-weight-bearing support. So you have non-weight-bearing support for limited assist, and then extensive assist is weight-bearing, and then total dependence for staff performance. Hopefully this training course was helpful in understanding the different ADL definitions and the history of ADLs and what they are. Thanks for completing this course.